cannot be caused by another active psychiatric condition. Two more. It must be clinically significant. And it must be stable over time, just like our personalities. So too, personality disorders must be stable over time. All right. So, and that will include aspects of the narcissistic personality as well. Unfortunately, with regard to stability and pervasiveness, anytime you watch any movie, it's hard to be definitive with regard to those two criteria. But that said, are there any other aspects of this character pertaining to those six that are a cause for concern for the clinician? So, so the observation of eating 5 dozen eggs might hallmark an underlying medical condition that we have to investigate. Okay. I think there's even one, even more perhaps straightforward than that. Yeah, I mean, I think before I would feel comfortable diagnosing him with narcissistic personality disorder, I would first want to evaluate for substance use disorder, specifically alcohol use disorder. Right? Because if he rules in for alcohol use disorder and he engages in an aftercare plan, a treatment plan, we maybe not be surprised if the narcissism, those narcissistic traits, actually abate, if they improve. So Gaston identifies that something clinically significant occurred in his life, meaning that he presents to you as a self-referral. He provides you a patient history synonymous with the plot of Beauty and the Beast, including his ingestion of alcohol. What's your next step? So you know now what you know. You've seen the film. What's your next step here if you're identifying his narcissism as clinically significant, something that he's coming to you for help for? What would you do for Gaston? Potentially get him into therapy. What aspects of the story do you feel compelled to confirm? Let's say he answers one of the 4 cage questions positive. What next? In clinical practice, unlike research, 1 out of 4 is a positive screen. Research, to be consistent across multiple research studies, it was arbitrarily agreed 2 out of 4 is a positive screen, about an 80% sensitivity, about 80% specificity. In clinical practice, 1 out of 4 bumps up the sensitivity of that screen to the mid-90s, which as a clinician you want, albeit at the expense of false positives. Right? The way to address the false positive is the same way you would address the positive screen in general. That is, you go to the structured clinical interview. You literally review the actual diagnostic criteria of alcohol use disorder to see if, in fact, it is a diagnosis. Hypothetically, let's say the answer is yes, and you diagnose Gaston with alcohol use disorder. What are you going to do for him? Right. So what stage of change? Let's hypothetically say that he is at the action stage, right? Because we want this conversation to continue. There are multiple teaching points to be made. So we're not going to say he is at pre-contemplation, nor are we going to say that he's at the contemplation stage? We're at the action stage. He's asking you, Doc, what can I do? What's the next step? So I'll give you a hint. The answer is going to be biopsychosocial, because the answer is always biopsychosocial. So what are some ideas you have? Treatment of alcohol use disorder as an outpatient. So no evidence of alcohol withdrawal, nor in your medical opinion do you believe he is at risk for alcohol withdrawal. So let's remove that from the equation. So, all right, let's review a couple of these things. Again, biopsychosocial. Number one, choose the quit date. He's done that. My quit date, Doc, was 2 days ago. My last drink. Okay. So you mentioned
I'm saying I
nicotine. Yeah, I know. That's all right.
Sorry.
That's okay. That's okay. That's actually important, and we'll get to why in a second. But you did say AA. Certainly, if the individual prefers Narcotics Anonymous, despite the fact that his drug of choice is alcohol, NA works just as well. You may want to get specific with regard to how or what he should accomplish with regard to task prior to his follow-up appointment. Maybe get a sponsor. Agree that the sponsor, that is, he signed an informed consent that allows you to speak with the sponsor. 90 meetings in 90 days. And the next time you come to our office appointment, let's make it for 1 week. I want to see a desire chip. Right? So AA, yeah. Mm-hmm. So that's certainly the psychosocial habilitation. If you think that there is something beyond that peer support that he would benefit from, one-to-one therapy, maybe CBT would be indicated. Don't dismiss that. All right. If you, on the other hand, don't find anything, peer support as a quote-unquote monotherapy to begin is just as fine. That's up to, again, what you believe is going on. There are narcissistic traits. Maybe they don't automatically go away with the cessation of alcohol. So maybe a referral to one-on-one therapy. So that's a consideration.
I just have a question about this narcissistic traits. Whether it be like considered like antisocial, because it kind of seems like this is hard for some others, and he like goes to these houses and just like breaks in, and he also just like has no respect for Belle, just kind of like walks into her house at one point, like without being invited in. I don't know, like when it would be considered. Or I think you have like a mix of traits, but when would we consider?
So, well, when to consider the antisocial personality disorder? So, I'm going to take on this question in two perspectives. Number one, in either case, we are going to wait 6 months before we render any diagnosis pertaining to any mental disorder. I want 6 months sobriety. I want 6 months of abstinence, working a recovery program before I begin to assess for a co-occurring personality disorder, whether we call it narcissistic or antisocial. Assuming we're at the 6 month point and we see clinically significant behavioral or personality traits, let's address that question from that other perspective now. How do you tell the difference between the antisocial versus the narcissistic personality? Again, luckily, both of these conform to a cardinal trait, which means, luckily, that when we actually think of the diagnostic criteria, they are much easier to remember because they're just examples of that cardinal trait in each case. Blatant disregard for and violation of others' rights, antisocial, versus the individual who believes they are special and can only be understood by someone as special as they are, the narcissist. From there, to really get at your question, we have to appreciate that the individual requires 3 of those for the antisocial personality and 5 for the narcissistic. And of course, the other qualifier is that with antisocial, the individual has to have demonstrated conduct disorder prior to the age of 15. That is not the case for the narcissist. These do cluster together, so there will be overlap. The bigger question at the end of all this is whether that overlap meets 3 and or 5, and therefore, are we going to diagnose both? That's what it comes down to. But again, none of this, if we see these traits improve in sobriety. It requires. Now, we have to be careful. If the individual appears to have had conduct, but never received an evaluation, access to health care was prohibited, like there was a significant barrier, cost, insurance, etc. You can't allow that to have the clinician say, well, therefore we can't call it antisocial, right? So there has to be evidence of conduct prior to. Whether it's truly diagnosed or not is another issue, right? But you do need evidence of conduct prior to the age of 15. Not the case for narcissistic. So we have him in AA. What else might we consider with regard to a biopsychosocial treatment plan for Gaston with regard to his alcohol use disorder? Whoops. I just dropped everybody watching us. Here we go.
While he's trying from abstinence or reducing the amount of alcohol he's using, is he experiencing cravings, and is there a medication that we can use to help aid?
So, Doc, yes, I am experiencing cravings.
So, there's different medications to consider.
What do we got? And students want to know what the 2 medications that are FDA approved for the treatment of alcohol use disorder that will cut down on cravings? Naloxone, right? All right. What is the mechanism of action of naloxone? It's a mu opioid antagonist. And as such, it will reduce cravings for opioids as well as alcohol. And so people using the mu opioid antagonist, binding to the mu opioid receptor and not activating it, will have a reduction in craving for opioids, which makes a lot of sense, but also have a reduction in cravings for alcohol because of the cross-receptor sensitivity. So that's definitely something you could prescribe. And if needed, you could even do Vivitrol, which is the long-acting injectable 1 time per month. So the individual takes an injection in your office and does not worry about taking the medication the other 29 days of the month. What is the other medication FDA approved for use that will work through the mechanism of reducing craving? Good, acamprosate. This looks to be structurally similar to GABA. So there's a thought it works through a GABAergic type mechanism. And the mechanism is really unclear, but what we do know is that it does not work through the mu opioid receptor, meaning that yes, it does reduce craving for alcohol. Yes, it is FDA approved for the treatment of alcohol use disorder. And number 3, you can use it with naloxone because of the different mechanism of action. The other times you might see this come up on an exam with regard to acamprosate is that it is secreted in the urine. And there are only a few psychotropic medications secreted in the urine. Anybody want to guess what the other 3 are? Lithium, good. 2 more. By the way, lithium comes up notoriously on tests. Lithium toxicity that is symptomatic goes to hemodialysis, okay? Not gastric lavage. Hemodialysis for symptomatic lithium toxicity, right? Kidney. Good. Gabapentin, brand name Neurontin. One more. Buspirone. Right? If you're okay with using the brand name, remember that the kidney is the bean-shaped organ. Bean, B-E-A-N. Buspirone, Escalith, which is lithium, acamprosate, and Neurontin, which is gabapentin. B-E-A-N, 4 psychotropic medications secreted through the bean, the kidney. There's another medication that we can offer Gaston here, which does not work through a reduction in craving. Disulfiram. So give me the enzyme that disulfiram inhibits. Be careful. Good. Good. Acetaldehyde dehydrogenase. Be very careful. That might be choice C or D. Choice A or B may be alcohol dehydrogenase. Do not read the answers too quickly. Right? It's acetaldehyde or aldehyde dehydrogenase. By inhibiting that enzyme, the individual has a buildup of acetaldehyde, which is toxic. All right? Toxicity from acetaldehyde results in what? What will your patient experience as a result? Flushing. Good. Right? Nausea, right? Diaphoresis, right? Vomiting, and they could actually presyncope and syncope. Yep, headaches. Right. Now, here's the $64,000 question. What type of learning is that? Say louder. It's operant conditioning. Specifically, what type? It is positive punishment. Right. Remember, the first question to ask on the with regard to your test question, the first question you're going to ask to yourself is the behavior identified strengthening or weakening? The objective here is to weaken drinking behavior, meaning that this must be punishment. Only punishment weakens behavior. So it's got to be punishment. The second question to ask is, to get there, do we add something or do we subtract something? Here we're adding a pill called disulfiram, which is Antabuse. By adding something, we're going to use the prefix positive. If we were to remove or subtract, we're going to call it negative. Taken together, positive, adding the disulfiram, punishment to weaken drinking behavior, positive punishment. Apply those two questions to any operant conditioning question on your test, and you can't get it wrong. Anything else you want to do for Gaston? I mean, what you just reviewed is a pretty standard biopsychosocial outpatient treatment plan for an individual afflicted with alcohol use disorder. What if Gaston tells you, I've been to AA before, I've been to NA before. It doesn't work for me. I don't like hearing other people's problems. It's a waste of time. Now, CBT or another form of individual therapy certainly is something that's on the table, especially if you think that there are indications for it. One of the things that we often have to remind our patients is that there is more to it with regard to attending AA or NA than hearing other people's stories. Sometimes people will benefit from your story, and maybe that's a role you can take on, and that is to share your story, which may actually save a life. A lot of people who are actively using are not thinking like that, especially if they've reached rock bottom or near it. But it's a good reminder that there actually may be part of your story that others will hear and will resonate with them, and it may change their life.
I think we should also inquire whether or not our patient has gotten a sponsor yet in AA and NA.
Absolutely.
Try to reach out to get one as the dating process and being involved.
Yes, it is. That's right. Overcome that awkwardness and ask for a sponsor, ask for help. Yep. The general idea here with regard to AA, and it applies to NA too, is being in the service of others. And we get back to the narcissism. Sometimes being in the service of others is very therapeutic. All right. Any final thoughts on Gaston? All right. Character number 2. Any other characters you want to discuss? Beauty and the Beast. Beast. So, what are your observations on Beast?
He's quite irritable, he's quick to anger. He's also like very reclusive. He doesn't want anyone else to see him. Has like much his castle appears. There may be some social anxiety or agoraphobia. But there also may be some like some explosive traits.
So, clinically significant irritability, perhaps even aggression, mood lability, social isolation, and reclusiveness. Anybody here disagree with that? And then, formerly, a human, I believe a prince, not without narcissistic traits, which has got him into this problem in the first place. Is Beauty and the Beast mindful of another story, a novel, with really the same exact theme? A narcissist who, due to his narcissism, turns into a beast hallmarked by irritability, reclusiveness, agitation, and aggression. Little Red Riding Hood? Is that the answer? You think Red's the yeah, The Strange Case of Dr. Jekyll and Mr. Hyde. Right? If you read The Strange Case of Dr. Jekyll and Mr. Hyde closely, or just read it at all, it is a story about the impaired physician. It is a story about alcohol use disorder. And there's a publication now that's over a decade old that actually reviews the DSM criteria. Back then it was the DSM-4, which really hasn't changed, over to the DSM-5, where the author actually identifies the diagnostic criteria in the story and references the exact page and line that rules the doctor in for alcohol use disorder. And we have a narcissist in our story, Beauty and the Beast, that transforms basically into another Mr. Hyde. All right, so in that way, in that context, Beauty and the Beast can be about alcohol use disorder when we focused on the beast, or perhaps more importantly, the prince as a focal point, a main character. So we discussed alcohol use disorder. Of course, we have to be concerned about alcohol intoxication. There might be signs of alcohol intoxication with regard to the beast's abnormal gait, alcohol withdrawal, and of course, some other alcohol-induced mental disorders as well. But certainly we've previously reviewed them, starting this morning with Seinfeld's The Red Dot, but they apply here as well, specifically to the beast character. I'm a little concerned that the beast is talking to teacups and pots. Certainly there might be a form of alcoholic hallucinosis here. Don't know if it's true alcohol withdrawal delirium. I don't really appreciate that there's a significant change in sensorium. So maybe alcoholic hallucinosis has to be investigated. Beyond that, any other thoughts about the beast? Again, I would throw caution at any idea to evaluate for a personality disorder. If we choose to approach this character as a remake, if you will, of Dr. Jekyll and Mr. Hyde, boy, we have to really focus on the alcohol use disorder before we go anywhere else pertaining to personality disorder. Any thoughts about the Beast? He could certainly be depressed. He absolutely can. I mean, certainly, again, if someone were to present to your clinical practice with the signs and symptoms that he demonstrates, we're probably not, as wearing this white coat and as clinicians, think that, oh, it's because of the curse. And boy, you have to get your act together before that final petal falls. I don't think any of us would be comfortable saying that in a clinical setting, especially if we have an attending looking over your shoulder, right? You're probably going to reserve that. That is, you're going to choose to view or interpret Beauty and the Beast through the psychiatrist lens. And depression, sure. Now, again, we have to be careful, very similar to personality disorder, not to attribute any mental disorder as an Nexus 1 pathology until we rule out the direct and physiologic effects of a substance, specifically alcohol. But certainly he's got significant dysphoria. So clinically, it bears watching. We'd be concerned. And whether it's induced by alcohol or not, I'm worried about suicide. Right? It does the clinician no good to ignore suicidality because we think it's substance induced. Right? So there's definitely a concern there. Especially when he starts talking about, I'm going to die when the last petal falls, or I'm going to remain as I am. That would be a concern.
I get a little bit of mania from him. His irritability, goal-directed behavior towards caring about, very specific things that he cares about. I get a sense of grandiosity and then he thinks he's the king of the castle. It's like he's the one that you listen to him, everybody listens to him, so I get that kind of maybe him in his beast form is an exaggerated way to say a manic episode.
Yeah, and to the extent that we have to consider a mood disorder, the bipolar disorder would take precedent. We wouldn't be able to talk about any depressive disorder until we evaluated for and ruled out a bipolar and related disorder. So, and putting this in a hierarchy, substance-induced, bipolar and related depressive disorders, right? 1, 2, and 3. So, yeah. Now, the other part of this too, I mean, thinking metaphorically or symbolically, how did we all learn the signs and the symptoms of mania? Right? Is there any scene in this movie where he's digging fast? Is he anything there? Could it have been Disney's way to tip us off that maybe this is about a manic episode after all? Is Dig Fast at all illustrated in this movie? I don't recall it, but if you go back and look more closely, if you uncover it, take the screenshot, send it to me, post it. One of the movies that I often use, totally unrelated to Disney, to teach bipolar disorder is Field of Dreams. And I had a similar conversation in presenting Field of Dreams as a fictional case of bipolar disorder in Ray Kinsella, the main character in the film. And I made a comment about Dig Fast. He was a farmer. And boy, so close to actually being able to catch a scene. And lo and behold, one of the people in the audience did send me the pic where he was digging. So it actually worked out well there. So similarly, if you come across that scene, please send it to me. Any other thoughts about the Beast?
I know Bell also saw them obvious talking and everything, but I don't know in the movie she actually specified that they were that Chip was a teacup, but the fact that Beast was definitely talking to them, thinking that they're all inanimate, but maybe they weren't. Maybe they were actually people, and he just thought they were. He turned them into teacup and kettle, chandelier.
Yeah, that's an interesting take. Whether or not Beauty and the Beast, the film, is actually a product of the Beast's mind, and specifically as a result of fantasy, and fantasy is a defense mechanism. in order to actually work this up, it would be nice to know additional information about his history that would support the use of fantasy as, in this case, a maladaptive defense mechanism. So if you were to write the prequel, what are some things you would contain in the prequel to support the film Beauty and the Beast as a case description of maladaptive fantasy? Or can you think of other films in which this was the case? Because then we could just borrow from those films in terms of what they actually illustrated.
You know that the witch cast a spell on him, that he needs to find all of his characters for the day. And he seems to be in this like peace phase for many years. So we can assume that he's fairly young at the beginning. And he's the one that refuses the witch entry, or the enchantress entry into the castle when she asks. So if he's the one who's in charge of the castle at that age, at that young age, where his parents can we, again, because it's Disney, can we assume a trauma history there?
Even neglect. Just their mere absence, I think, supports this idea of fairly significant neglect where he's answering the door to strangers. And perhaps due to that neglect, he is resorting to fantasy as a form of self-soothe, to create this autistic world where he's a prince, and therefore he doesn't need mom and or dad omnipresent. That works. Yeah, that absolutely works. Right? The bottom line, whether it's in the prequel or whether it's intimated in this movie, we would expect clinically significant neglect with regard to childhood, where as a result, the child incorporates the defense mechanism of fantasy. We usually see this in film brought about due to severe childhood illness, where because of their illness and because of their constantly being hospitalized, they're never able to form early bonds with peers, and therefore have to form those bonds with imaginary friends. In M. Night Shyamalan's Unbreakable, those imaginary friends are from a comic book of Elijah Price, due to his osteogenesis imperfecta. Right, so that's a recurrent theme. Early childhood illness results in significant isolation, failure to establish peer bonding, and therefore the bonds that are established through fantasy are what is maintained then into adulthood, whether it's a comic book or otherwise. Any other characters? Any other questions about alcohol? Have we reviewed the treatment for alcohol withdrawal? I know we jumped to the outpatient treatments. Have we reviewed the treatment for alcohol withdrawal? Everybody comfortable with that, or anybody want a review of that? Comfortable with it? All right, so that's why I get a consensus. If that is the case, we will end here. We will take a 5 or 10 minute break. For those of you who have the link, meet us at our case conference. Give us 10 minutes to set things up, and we'll be right back. Thank you.